to those moms that are out there. Because of the Mother's Day holiday, I had to come on earlier than our regularly scheduled time to record today's session because my family actually has something prepared for me that I was not aware of until about 15 minutes ago. So I'm sorry that I had to come on and record early, but I will see you guys next week. So let's talk about what's in store for week number 2. One of the things that I think it's important for you to know regarding this class is that there's a lot of material that is covered over the next 7 weeks. And as you guys know, all of our courses are 7 weeks plus the final exam, which is week 8. And so one thing that is, I would say, challenging regarding coding is that I believe that oftentimes some people believe that after 8 weeks of this class that you're going to have expert level knowledge, and you're not going to have expert level knowledge. What you will have is an introduction to this particular subject matter. And the purpose of these live lectures and the other activities that we have going on throughout this term is to help ease the apprehension or frustration that some of you may be having with learning all of this material. So when I think about this particular course, I say that we have 3 main objectives. Number 1, you're learning how to assign ICD-10 CM codes. We talked about that last week. Then you are also learning the ICD-10 CM guidelines. So as a reminder, it's going to be very important that you have a hard copy of the coding manual or guidelines so that you can make notes on your guidelines so that as you begin to prepare for your credentialing exams, that you have all of that information available at your fingertips. And then the third component is abstracting and coding inpatient records. You have learned about the components of the health record in HIT 120, one of your very first classes. You have learned what the word abstracting is. You have taken medical terminology, anatomy and physiology, pathophysiology, pharmacology, and all of those courses that came before this course is really helping you. It's really positioned you for being able to learn the basics of abstracting and coding inpatient records. Okay, so these are our 3 main objectives each and every week. So let's talk about what you can expect for week number 2. Number 1, you're going to be reading 4 chapters, and the chapters are not long, but I want to just caution you that the beginning of the chapters start with ICD-9-CM. I do not recommend that you read that part of the chapter because I believe that it will confuse you. So read it at your own risk, but keep in mind that we are focusing on ICD-10-CM and not ICD-9-CM. And I had actually seen in one of my own classes where some folks were talking about ICD-9, and I think that's very confusing. Very confusing. When you're learning about this system and how the book is set up. So, as I mentioned last week, we are really caught in a situation where the industry has converted over to ICD-10, and the book publishers we're continuing to publish ICD-9 and ICD-10 in a book together because we weren't really sure when we were going to convert over. And for those of you who don't know the history, ICD-10 was delayed a couple of times before it we actually converted over last October 1, 2015. So we've only been using it for a few months. So again, as I stated last week, that's the reason that that is the reason that your textbook is discussing both. But I believe it's quite confusing if you read both parts of the textbook chapter. So you'll notice in the course syllabus, when it gives you the chapter name, it actually even tells you which pages to read. So just keep that in mind as you're going through the material. And basically what the author is doing in the chapter is reviewing the guidelines. So you guys know where the guidelines are. You should have a printed copy in your possession because it will prove to be very beneficial to you during this process. Okay, so these 4 chapters that you're going to be doing, that you're going to be reading, and at the end of each chapter, there are coding exercises, and the answers to those exercises are actually in doc sharing of your course. One thing I will tell you is that your homework and quiz, your success on the homework and quiz, is really going to be based upon you reading the chapters, reading the guidelines, understanding the guidelines, and then being able to assign codes. And the reason I say that is for weeks 2 through 7, your homework is really going to be focused on guidelines and your chapter readings, whereas your quiz is based on your ability to read the scenario and assign a code. So if you have been reading the chapters, if you have been reading the guidelines, if you have been answering the questions at the end of the chapter, checking your work, you have a pretty good chance of doing well on the homework and quizzes. Keep in mind with if there are true and false questions, it's either true or it's false. So if it's half true and half false, your answer selection has to be false. Okay. And then the other item that you're doing for this week is going to be inpatient cases 11 and 39, which are available in your particular round table areas. Now, I want to give you fair warning that with the round table exercises, you can't wait until the last minute to work on those because it does take you, it will take you a few days to get through them. Last thing I want to say about the quiz, just to kind of, again, ease some of the apprehensions that you guys may be having. The scenarios for the quiz are really like a few words, no more than a sentence. And each of the scenarios only has one code. So it should not be overwhelming. You just want to make sure that you are following correct coding processes, that you understand and are applying the guidelines when they apply. All right, so let's talk a little bit about the guidelines for this week. So as I mentioned, we are really, with this class, we're going to climb our way from the beginning of the guidelines to the end of them. And as you may recall from last week, the ICD-10 CM does have 4 sections to the guidelines plus an appendix. And for the next 6 weeks, we are really going to spend a lot of time with going through the different chapters of the tabular list. Keep in mind the chapters of the tabular list are not the same as the chapters in the textbook. Okay, so we're going to be looking at first chapter specific guidelines, certain infectious and parasitic diseases. And as I mentioned before, during the live lectures, I'm going to be utilizing a printed copy of the physical guidelines because the guidelines in the book tend to be a smaller font and a little difficult to read. Also does not allow you to make a lot of notes. So I like the printed copy, yes, the 115 page document, because I can write notes directly on this document. I will tell you something that you should know and become familiar with is in your tabular listing to your ICD-10 CM manual, they repeat the guidelines there, but something that I think is very, very helpful, a must read every week, is that you are given example scenarios. They're in these purple boxes in the front of each and every tabular list chapter. So if you were to go over to the chapter for infectious and parasitic diseases, you'll see that they have the guidelines, and pretty much almost under every guideline they have some examples. And I think those examples do a really good job of illustrating how that guideline should be utilized. So in your physical guidelines, the 115 page packet again is what I'm using. On page 17 is where we have our guidelines for infectious and parasitic diseases. And it starts off with guidelines for HIV infections. One of the things that is very important in this class, I have to tell you, is your willingness to research things that you perhaps have forgotten about, as well as information that you may not have learned before. And so the reason I bring that up is for HIV infections, HIV AIDS, there are some important things that you need to know, such as the different types of conditions that a patient that has HIV is more susceptible to having. Those are known as opportunistic infections. In the files area, you'll notice that I've uploaded a lot of files on today. Definitely, get these files and download them and read them. But I uploaded one related to HIV related conditions, and that's going to be important as it relates to one of the guidelines. So let me share with you the guideline that I'm referring to. So under HIV infections, again, I'm on page 17 of the guidelines. You will notice that under letter A, which is human immunovirus infection, number 2, selection and sequencing of HIV codes, you have guideline A that says, if a patient is admitted for an HIV-related condition, the principal diagnosis should be B20, followed by an additional code for the HIV-related conditions. So I provided you with a list of HIV-related conditions, and if you're looking at a scenario where a patient has HIV and they also have something like pneumocystis carinii, you would have two codes. If the patient currently has pneumocystis carinii, you would have a code B20 to show the HIV disease, and then you would have a secondary code for whatever the code would be for the pneumocystis carinii. Okay, so that guideline is really in the driver's seat in terms of how we sequence. Let's look at another one. B, if a patient with HIV disease is admitted for an unrelated condition, such as a traumatic injury, the code for the unrelated condition should be principal, and then other diagnoses would be B20, followed by additional diagnosis codes for all reported HIV conditions. So reviewing the documentation is going to be key, as well as applying the guideline. Let's see, other things. I should mention that if you have not read chapter 3 from last week, that is like a must-read chapter because it does cover an introduction to the guidelines, one in particular, the definition of principal diagnoses, how we determine the principal diagnoses, as well as secondary diagnoses. That's going to be very, very important to your success in this class. All right, let's look at some other options. Sepsis, severe sepsis, and septic shock. So for this particular area, it is noting that for a diagnosis of sepsis, we are to assign the appropriate code for the underlying systemic infection. But if the type of infection or causal organism is not further specified, we're going to use A41.9. That's one guideline. Then there's a whole bunch of them under where it says letter A, sepsis. On page 21 in the guidelines, for severe sepsis, the note there says the coding of severe sepsis requires a minimum of 2 codes. First, the code for the underlying systemic infection, followed by a code from subcategory R62, severe sepsis. Then there's a note that says if the causal organism is not documented, we're going to assign code A41.9, sepsis organism unspecified, and then additional codes if the patient also has acute organ dysfunction. So there's also a note, due to the complex nature of severe sepsis, some cases may require query to the provider. So last week, you were provided with an opportunity to determine if we should query regarding what was documented. The query process is something that does take time to learn. So don't be frustrated if you got a particular, if you didn't get everything for that round table last week. Keep in mind that you are being graded based on your participation, based on the rules and regulations that are listed under assignments. For those of you who perhaps did not listen to the week 1 lecture, I'm going to upload the query process articles here again, but I will tell you that 1 week of the live lecture builds on the next. So you may hear me referring to things that we talked about in the previous week, and if you're not keeping up with the lectures, you may find that it may be a little difficult. Okay, so there are a bunch of other guidelines here for certain infectious and parasitic diseases. Unfortunately, during this setting, I do not have time to go through each and every guideline. That's what you are supposed to be doing on a weekly basis as you're reading your chapters and you are reading your guidelines. Okay, so let's go on to now neoplasms. And neoplasm guidelines begin on page 25. Again, I am using the physical copy of the guidelines. And so on page 25, I want to look at some general guidelines for coding neoplasms. In the first paragraph, there is a notation that says, to properly code a neoplasm, it may be necessary to determine from the record if the neoplasm is benign, in situ, malignant, or of uncertain histologic behavior. Then it also says, if malignant, any secondary sites should be determined. And secondary is a situation where the cancer spread. You'll see words like metastasis or metastatic. So that's the first guideline that I wanted to point out. The second, still on page 25, says the Neoplasm Table in the alphabetical index should be referenced first. However, if the histological term is documented. And what do we mean by histological? Anytime you see a word, you don't know what it means, you have to look it up. The histological term is the type of tissue. So words like lymphoma, sarcoma, leiomyoma, myoma, carcinoma. Those words that end in a oma. That are some examples of um, the histological term. So if the histological term is documented, that term should be referenced first rather than immediately going to the Neoplasm table. And I'm going to show you a little snippet of the Neoplasm table shortly. So lots of guidelines related to neoplasms. Again, each and every week, read the guidelines. I especially like in the physical coding manual, directly before the codes, they give you the guidelines and some examples in the purple boxes. So very important to read those. So let's look at a couple of them that are important. So let's look at admissions encounters involving chemotherapy, immunotherapy, and radiation therapy. So in particular, I want to look at number 1. It says when an episode of care involves the surgical removal of a neoplasm, primary or secondary, followed by adjunct chemotherapy, radiation therapy during the same episode, the code for the neoplasm should be sequenced as first or principal diagnoses. Then the next paragraph says if the admission encounter is solely for the administration of the chemotherapy, the immunotherapy, or radiation therapy, it tells us which codes to list first, which are the Z codes. What I'm trying to illustrate here is that in order to accurately assign codes, if a guideline applies, you have to ensure that you follow that guideline. Again, in this platform, do not have the time to go through each and every guideline because that would literally take us hours, okay? So read through the guidelines and become familiar with them while you're coding this chapter. One last one that I do want to look at, which is typically a common problem, is current malignancy versus personal history. One of the reasons I wanted to look at this guideline is because physicians don't know coding. And they will commonly say, oh, history of breast cancer, had chemotherapy today. Well, as coders, we have to apply coding guidelines, which basically state that when a primary malignancy has been excised, but further treatment, such as additional surgery for the malignancy, or radiation therapy, or chemotherapy, is directed to that site, primary malignancy code should be used until treatment is completed. So if they're actively treating that cancer, it's not a history of cancer, it is an active cancer. Again, physicians don't know coding. They aren't trained in all of these rules and regulations. So it is up to us to apply the guideline and say, okay, even though the provider said history of, according to the guidelines, this patient has current cancer. Now, you're not diagnosing the patient. You're merely just using the guidelines to ensure accurate data capture of that particular code. Okay, and then there are some other guidelines that are listed here, some which they are referring you to other parts of the guidelines. Okay, here is a copy of what the Neoplasm table looks like. A couple of things I want to point out. Number one, the Neoplasm table is after the index to diseases and injuries. Okay, and the Neoplasm table itself is divided into 6 columns. So what you should notice is that Your malignant codes, whether they're primary or secondary, start with the letter C. And then your carcinoma in situ, your benigns, your uncertain behavior, your unspecified behavior, they start with the letter D's. The letter D shares codes with the blood disorders of the blood and blood forming organs, but it begins at D50, the blood codes, whereas the in situ, benign, uncertain behavior, unspecified behavior, they are the letter D all the way up to D49.9. So one thing that's very important to note about the Neoplasm table is that guideline that I just went over. And let's review that guideline again. The Neoplasm table in the alphabetical index should be referenced first. However, if the histological term is documented, that term should be referenced first rather than going immediately to the Neoplasm table in order to determine which column in the Neoplasm table is important. And again, that was on page 25 of your guidelines. The other thing that's very important to know is that we never code from the Neoplasm table. As a reminder, we must always verify our code in the tabular list. That's going to be very, very important. Okay, so that's all for neoplasms. Going to go over to diseases of the blood and blood forming organs. And what you will notice in looking at the guidelines, the physical copy, page 31, says reserved for future guideline expansion. There are 21 chapters in the tabular list, and not all of them have guidelines because the cooperating parties, AHIMA, AHA, CMS, and the National Centers for Health Statistics said that they don't have any guidelines to report at this time. So what we do is, every year we make sure that the guidelines that were in there last year are the same. If there are any changes, we're going to, take a look at them. And then other than that, if there are no guidelines here, you're going to follow any instructional notes from your tabular list, and that's it. Okay, so our last chapter for today is endocrine, nutritional, and metabolic disorders. And one thing I would like to note about this chapter, while the guidelines really focus on diabetes, there's more than just diabetes in this chapter. For example, we have codes for dehydration. We have codes for conditions like hyperkalemia. So any type of endocrine, metabolic, and nutritional disorders, that's what you're going to see in this chapter. But the biggest part of this chapter is going to be your diabetes. It is the biggest part of your chapter. And what I would like for you to do at this time is to open your coding manual and go to the main term, diabetes, because I want to show you something. So in the alphabetical index, main terms are in bold print. And remember that if your main term says continue, that means you're not at the very beginning. So I'll give you a few seconds to get over to the main term, diabetes, in your alphabetical index. Okay, so as illustrated on the slide here, there are 5 categories of diabetes codes. E08, diabetes due to underlying conditions. E09, drug or chemical induced diabetes. E10, type 1. E11, type 2. And then E13, other specified diabetes. Given the fact that there are these 5 categories, it is very important when you're in the alphabetical index to ensure that you are referencing your subterm properly. So, for example, if you go to main term diabetes, you'll see the default code is E11.9, which type 2 diabetes is the default. The doctor doesn't state what type of diabetes they have. The default is type 2. Then you'll notice under diabetes, you have with. These are the different types of manifestations the patient can have. And you'll notice all of these codes all of these codes start with E11. Okay. Then the next column says, and I have this highlighted in my book because it's easier to find, but the next big major category of codes is diabetes due to drug or chemical induced. And as I just mentioned, that's category E09. So you'll notice under due to with drug or chemical, there are some with. The with manifestations, because patients that have diabetes oftentimes have other conditions that manifest as a result of the diabetes. So you'll notice things like cataract, hyperglycemia, hypoglycemia. Okay. The next big area of subterms under diabetes due to underlying condition. So remember, that is category E08. And you'll notice that those codes begin with E08 and then at some point they end. And the next big area of codes you'll see is specified type. And I'll tell you, I have the 5 types highlighted in my book because sometimes it can be overwhelming to see all of the subterms. So if I know, okay, diabetes has 5 types, I'm going to have the 5 types highlighted so that I can reference them very quickly. Okay, so specified type, E13. Then on that same page, third column, type 1. And then if you turn the page, you'll see your type 2 codes. So one of the things that you should see that's very important, after you go to main term diabetes, you must go to the correct type. And I'm going to explain to you why. If you look at diabetes due to drug or chemical with a cataract, that gives you E09.36. But if you go to diabetes due to underlying condition with cataract, it gives you E08.36. If you go to diabetes specified type with cataract, that gives you E13.6. If you go to type 1 with cataract, E10.36. Same thing, type 2 with cataract, E11.36. So you can see how important it is for you to verify your code or your subterm entry. All right. So that kind of concludes the first part of the chapters that we're going to be working with this week. Important again that you read the textbook chapters, that you read your guidelines, that you complete the exercises at the end of the chapter, because again, on your homework and your quiz, you are going to be coding. You're going to be responsible for knowing the guidelines. Okay, so the next part I want to talk about is the inpatient coding process. Now, I want to tell you something that I think is very important for you to know, and that is inpatient coding is the hardest type of coding. Inpatient coding typically takes a few years to master. And I don't want you guys to be frustrated by saying, oh, I didn't get everything right. The goal is for you to learn the process. And when you're at a hospital and you're coding 8 hours a day, 40 hours a week, you're able to apply what you've learned to then increase your speed, to then increase your accuracy. But it's something that you have to be doing all day, every day. All right, so the inpatient coding process, there are some resources that you want to ensure that you have. The very first resource is going to be your ICD-10 CM coding manual and guidelines. That is because that's what an inpatient coder uses. Oh, I didn't put it on this particular slide, but some of the cases will require an ICD-10 PCS code, and so you'll want to have that manual as a resource when it applies. Okay. With inpatient coding, from time to time, you will have to determine that a query is needed. So last week, you had 2 query process articles that you were to read. I've uploaded them to the files area for those of you that didn't read them last week. They are must read articles for the inpatient coding process. AHA Coding Clinic. Coding Clinic is a reference that is inside of the 3M system. I am going to upload an article to the files area that talks about how you locate the Coding Clinic articles. I highly recommend that you download that particular article and be familiar with how we locate Coding Clinic articles, because you really are going to need to refer to them. Then the next resource, Medical Dictionary, or the internet. Because as you're reading through the inpatient medical records, you're going to find that there are going to be words that you don't know. Whenever you see a word that you don't know, it's going to be very important that you research that word and become familiar with it. A drug handbook. Throughout the medical record, you're going to see different medications. It is important for you to not only know the names of those medications, but also be able to identify what conditions those patients have related to that particular medication. Your pathophysiology book. Your pathophysiology book is important because you need to go back and review the different diseases, the signs and symptoms for that disease. You need to know the different diagnostic tests that they perform, whether it's blood or urine or x-rays. You also need to know how certain conditions are treated, whether it's a medication or whether it's surgery. And then another resource which is very important is an abstracting worksheet. And I have uploaded several documents to the doc sharing or the file sharing area. And the abstracting worksheet will be one that I will upload in a few minutes here. Okay. So with this process, it is very important that you know your inpatient guidelines. So I want you to turn over to the guidelines, specifically section 2. This is what you were actually supposed to read last week as it relates to chapter 3. So I'll give you a second to go and find those. And hi, Donna, I see that you joined. This session is being recorded. And because of the holiday, the Mother's Day holiday, I had to come in and record this session early because my family is taking me out to dinner. And so that's the reason why I am here early. So I've been on for close to an hour now, just kind of as a FYI. Okay, so guidelines that are going to be very, very, very important to the inpatient coding process is A, selection of principal diagnoses, and then B, selection of other diagnoses. Again, I do not have time to read through all of these guidelines for you. One of the things that I hope that you did last week was complete the exercises at the end of chapter 3 in your textbook. And the reason why those questions at the end of chapter 3 really helped you understand what's meant by principal diagnoses, how we determine the principal diagnoses, and why that is important is because of your coding roundtable this week. In your coding roundtable for weeks 2 through 7, you have 2 medical records that you're going to be abstracting and coding from. Oh, also in the files area, I have uploaded some articles. One is abstracting from inpatient records, 2 inpatient coding tips for new coders, and then there's another one that should be there, which is called the mechanics of the inpatient chart review. So those documents are very, very important because the inpatient records, because they're longer, they tend to be a little bit intimidating. All right, so what's going to happen is each and every week you're going to read through 2 cases, and from those 2 cases, there are 9 questions that you have to answer for each and every case. Now, I am going to cover the first case today, and you will notice in the files area, I have uploaded a template for you to use when you are doing your coding roundtable, and it will help you understand, number one, the codes for the first case, but also it will help you understand the format of how your answers should look. So for each and every case, which is 2 per week, you need to type in what the admit diagnosis code is. So in order to determine the admit diagnosis code, you have to look through your record and identify why was the patient admitted today. Next, you have to pull out of the record what is the discharge status. What that means is, where did the patient go upon discharge from the hospital? In doc sharing, there is a list of discharge statuses. We also call them discharge disposition. That is one of the documents that I mentioned last week that you need to have in your reference binder. So again, one of the things I want to tell you is that if you did not attend or listen to the week 1 lecture, it is very important that you do that first prior to getting fully involved with this particular lecture, because each week I'm building upon what was covered last week. Okay, the next thing, the third item, is your principal diagnosis code number. So I had you go to your guidelines to look for the section 2, which is the selection of principal diagnoses. So the principal diagnoses is not determined by the doctor, because doctors don't know coding rules. The principal diagnosis is the condition that is established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Doctors just list the diagnoses. They don't list them typically in a order as it relates to coding. So it's up to us to take coding guidelines and apply them. So principal diagnosis code number, we only list one only, with a POA indicator. Well, what's a POA indicator? That was also covered in Chapter 3 of your textbook. In your physical coding guidelines, if you go over to page 105, again, as I mentioned last week, I'm going to be talking from the physical copy. But on 105 of the guidelines, you have appendix number 1, which focuses on the present on admission reporting guidelines. Okay, so that's very, very important to know. So back to principal diagnoses. For principal diagnoses guidelines, you have several guidelines to consider. A, codes for signs and symptoms. B, when you have 2 or more interrelated conditions, each potentially meeting the definition for principal. C, 2 or more diagnoses that equal the principal diagnoses. 2 or more comparative or contrasting conditions. Again, the textbook, chapter 3, gave examples of this. If you have not read it, very important. Letter E was deleted as of October 1, 2014. Letter F, what do we do if the original treatment plan is not carried out? Letter D, complications of surgery and other medical care. H, uncertain diagnoses. I, admission from the OBS unit. And J, admission from outpatient surgery. And lastly, K, admissions and encounters for rehabilitation. So before you determine what your principal diagnosis is, you really have to know these guidelines. You have to know more than just the definition of principal diagnoses. You need to be able to identify which one of these guidelines will actually apply. And then, of course, per the guidelines, for your principal and your secondary diagnoses, you have to have a POA indicator. Speaking of secondary diagnoses, on page, let's see here, page 99, again, I'm using the physical copy of the guidelines, the 115 pager. On page 99, for secondary diagnoses, other diagnoses are secondary diagnoses, FYI. So for reporting purposes, according to the guidelines, for reporting purposes, the definition of other diagnoses is interpreted as additional conditions that affect care in terms of requiring clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, and increased nursing care. So that's one of the criteria that has to be met in order for you to even begin considering if a secondary diagnosis or other diagnoses are to be picked up. The guidelines further state, this is again from chapter 3, I cannot emphasize, if you did not read chapter 1, 2, 3, and 24 from last week, it is critical that you keep up with the readings. So the guidelines further state that other diagnoses are all conditions that coexist at the time of admission, that develop subsequently, or affect the treatment received and or the length of stay. They further go on to say that diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. Well, what does that mean? That means you're going to see all type of historical conditions listed in the medical record. And before you pick them up, you got to remember this rule. Diagnoses that relate to an earlier episode which have no bearing on current hospital stay are to be excluded. All right, then for other diagnoses, you have a guideline A related to previous conditions, B, how we handle abnormal findings, and C, how we handle uncertain diagnoses. Okay, so then the next thing that you're being asked in the round table is, what's your principal procedure? What's your secondary procedure? So let's look back to ICD-10 PCS. So what we are primarily coding here are going to be procedures that are significant in nature. Chapter 3 in the textbook. I hate to keep going back to that, but that's very important. Chapter 3 in the textbook spoke about the concept of which procedures we should be capturing. From your HIT 203 course, hopefully you have not gotten rid of those guidelines because you're going to need them. And because there is a guideline on page 15 of those guidelines that talk about the selection of the principal procedures. So if you didn't have a copy of those PCS guidelines, you probably want to get one and refer to them, because there will be some procedure coding in the roundtable. Now, I will tell you not to worry. I'm actually going to tell you each and every week when procedures are needed. That way you won't be spinning your wheels trying to figure out if a procedure should be coded or not. So let's stop here, and I'm going to pull up our first case for the week. Okay, so our very first case for the week is case number 11. And what I would recommend that you do is to read through the case one time just to become familiar with it. Also, read through the case to look up any words that you don't know. Okay, that's very, very, very important. Okay, very, very important. One of the most difficult skills to learn is inpatient coding. Okay, hands down, it is the most challenging type of coding. So using our case number 11, I want to talk about some things that you need to know. Number one, it is our goal to assign diagnoses and procedures correctly. Why? Because it enables us to assign the most accurate MSDRG. And you'll notice for your roundtable cases, you have to determine what the MSDRG is each and every week. Earlier this week, and let me just provide this in the chat box. 1 second here, let's see. I recorded a session on how you use the 3M encoder to determine your MSDRG. It goes along with this particular week's live lecture, but because this process can be pretty lengthy, pretty intimidating, I decided to record it separately so that you could see me going through the encoder to determine what your MSDRG is going to be. Okay, so let's look at this record here. The very first thing that we do, okay, the very first thing that we do is always, always, always begin with the discharge summary. We begin with the discharge summary because it gives us an overview of what happened to the patient today. So this particular discharge summary starts off with the doctor saying that the patient has influenza with gastroenteritis and dehydration. They also have Parkinson's disease. Now, you'll notice here that there are potentially several diagnoses that are listed. And on the previous slide, I mentioned, and it also says in the coding roundtable, let me pull that up. In the coding roundtable, it tells you one diagnosis for the admission only. So I will tell you that we do not get paid based on the admission diagnosis. So really, you read through the record and you identify, okay, why was the patient admitted? What is going to pay us our money is our principal diagnosis, which again is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. So it's important that you figure out what that principle is. Okay, so back to this case. The doctor says discharge diagnoses, gastroenteritis, Parkinson's, laxative abuse, and osteoporosis. Again, doctors don't know coding. And so while the doctor has listed diagnoses here, that's not all that you should be coding. Okay? Remember, according to the guidelines, all conditions that coexist at the time of admission, that develop subsequently, or that affect the treatment received and or the length of stay are secondary diagnoses that we have to code. So let's look at the discharge summary for this patient. And I'm going to give you guys a few seconds to read through this discharge summary. Okay, so I'm going to continue, and if you are listening to the recording, what I recommend that you do is pause the recording if you're not finished, but I'm going to go ahead and continue. So one of the documents that I mentioned that I uploaded to the files area was an abstracting worksheet. And the abstracting worksheet that I mentioned, I think would be very helpful when you are coding these roundtable cases. So I'm going to pull up that abstracting worksheet, and I had it here earlier. Okay, here we go. The reason why I would print this out and read it is because, and use it, it helps you capture your codes, capture what you're thinking about. So first thing you'll notice on this worksheet, admitting diagnoses. Then I even have the definition. Describes the patient's diagnosis at the time of admission, most often a symptom, One admitting diagnosis is reported, required on all inpatient claims, and I reiterate that it's not used to calculate the MSDRG. You should also notice that I have a big black box for POA indicator because the admission diagnosis does not receive a POA indicator. You will also notice that I have a blank spot for you to document where it was documented, if there was a coding clinic that assisted you in arriving at your decision, or if you need to query. Typically for the admitting diagnoses, there is no need to query. But in this case, we should clearly identify why the patient was admitted. Well, if you look at that, discharge summary, it actually says it. She was admitted and given IV fluids for 2 days, which did help significantly. So why do we get IV fluids? Because we're dehydrated. So if I were you, I would, use this sheet, and I've made it so that it's a Word document, so that I'm spelling dehydration wrong. I've made it so that it's a Word document, so that you can organize, rearrange this sheet if you want to, but I recommend printing this out with a pencil. So the admitting diagnosis is dehydration. Now, you're probably thinking, well, up here, they said influenza, gastroenteritis, dehydration, Parkinson's disease. But if you look in the discharge summary, it says she appeared quite dehydrated. And Dr. Whatever felt that admission for IV fluid therapy was necessary to prevent further complications. She was admitted and given the IV fluids. Okay, so remember that the admitting diagnosis is why they were there. So in my little box here, I'm typing in that it's dehydration. The next thing I have to identify is what's the principal diagnosis. That condition established after study to be chiefly responsible for the patient's admission. Well, after study, as we read through this record, you read through this entire record, you'll notice that after studying, really the focus was on the dehydration. So not only is my admitting diagnosis dehydration, my principal is dehydration as well. Now, for your coding roundtable, you notice that it says admit diagnosis code number. So even though I wrote the words dehydration here, you will have to pull out your coding manual and locate the actual code for dehydration. Okay, but for now, I'm just showing you how I'm using this sheet to track my notes. Also, I have a POA indicator column here. And was this present on admission? Absolutely, it was present on admission. Now, if you notice, for POA indicators, I have to choose between Y, N, U, W, and exempt. Again, if you have not read Chapter 3, you got to read Chapter 3 before you can do what you're being asked to do in the roundtable. Also, as it relates to the POA indicator, you have to read the POA indicator guidelines. In fact, one of the things that we're going to do in our week 3 lecture is we're going to have a POA challenge where I'll give you scenarios and you determine if the condition was present on admission. So let's continue. In looking at this record, now I need to pick up my secondary diagnoses. Well, I got a few up here. Gastroenteritis, Parkinson's, laxative abuse, osteoporosis. So again, I'm going to take out my little sheet. Again, you can handwrite this, you can type it, but I'm going to type in all my secondary diagnoses. Now you notice I'm not putting the codes in yet because I do need to read the rest of the record to determine if if the condition was truly treated. Remember, according to the guidelines, for reporting purposes, the definition of other diagnoses is interpreted as additional conditions that affect or that require clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, or increased nursing care and or monitoring. They further state all conditions that coexist at the time of admission that develop subsequently or affect the treatment and or length of stay meet the requirements for secondary diagnoses. Okay, so I am looking at the report. The doctor also stated, let's see, after the gastroenteritis, they talked about the Parkinson's disease. Okay. The doctor also mentioned that the patient has a laxative abuse. He also mentioned that the patient has osteoporosis. And in the actual note, the doctor actually mentions that the patient has the chest x-ray revealed a severe compression fracture with kyphosis. So you got to first know what a compression fracture is. So when I made the recommendation that you first read through the record and look up words that you don't know, this will help you when you are coding to determine yes or no, I'm actually going to pick up this condition. So the patient has osteoporosis and they have this compression fracture. There is actually one code that actually says both. So I'm going to just type over here with a compression fracture so that as I'm beginning to go through the record, I can ensure that I capture all this. Oh, I also have to say, is it POA? So I'm going to say yes for the Parkinson's, yes for the gastroenteritis, yes for the laxative abuse, yes for the osteo. Okay, let's see what else they got going on here. Now, they mentioned that she had an elevated LDH, total proteins were low, and then they also mentioned that she had a splenectomy in the early years, and this may account for the slight elevation of the LDH. Now, there are some status codes, Z codes, that we could pick up that shows the splenectomy status. So I'm going to type it out here. Status post splenectomy, and the status post splenectomy codes or status post codes, they really don't give us any more money. So this would be something that your organization might say, yes, we want you to pick up, or no. I will tell you, for our answer key for this case, we are not picking it up. And that's because when we read through the record, we discovered that, yeah, they mentioned it on the home page, but according to the guidelines, you notice I keep going back to the guidelines, but according to the guidelines, diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. So you may work at a hospital and they say pick all that stuff up, or you may work at a hospital that says don't pick it up. The hospital that you work at that says pick it up, they may want you to pick it up for data collection purposes. Okay, so let's see what else is going on here. More blood test results, and they said that she has anemia, and it was hyperchromic normocytic. So I'm going to put down on my little sheet here, the patient has anemia, it was hyperchromic, and it was normocytic. So again, you notice I'm not writing, was it hypo or hyper? It was hyper. Also make sure that you got your right terminology. So it was hyperchromic and not hypochromic. Okay, so back to the record I go. Let's see what else I got here. She was given some laxatives and enemas while she was there, and she did begin to feel better and eat better. Then it lists her medications. Now, remember I said earlier how important it was to read through the medical record, research things that you don't know? Well, one of the things that you probably don't remember that you should research are these drugs. So, for example, she was continued on her Symetrel 100 BID, so 100 milligrams twice a day. Symetrel is used for Parkinson's disease. Well, that makes sense, right? Because she has, it's a she or he, she has Parkinson's disease. And again, going back to our guidelines, I know you're like, wow, she keeps saying these guidelines, but I want to illustrate how key they are. For reporting purposes, the definition for other diagnoses is interpreted as additional conditions that affect patient care in terms of requiring clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, and increased nursing care. So the fact that the nurse has to give the patient this medication, that's a secondary diagnosis that we're going to capture. Okay, let's see what else. Clinaril. That is a non-steroidal anti-inflammatory drug. Okay. She also was given, she used to use the Oronade for sinus congestion, which she complained about being quite bothersome for the last 24 hours. Now, I will tell you that we see this note here about the sinus. We see in the medication administration record that the doctor prescribed that medication. Some coders would say, yeah, they gave him the medication. It's listed in the discharge summary. However, according to the guidelines, diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. So some coders would say, yeah, I'm going to code this. And some coders would say, no, I'm not going to code it because it did not impact the stay. Okay. Now we're just on the discharge summary. You see, we're having all this conversation about the discharge document only. That's why, again, I want to be very clear to you that inpatient coding takes time to learn because there are so many different things that go into it. That's why in the coding roundtable, you're not being graded based on the correct answer. You're being graded based on, hey, by Wednesday, and let me just show you this. This is also in the files area. By Wednesday, you have posted your cases. You have the 9 questions answered for case 39 and the 9 questions answered for case 11. That's what you're being graded on, not whether or not they were correct. Okay, so let's continue. So let's see what else she got. We talked about the Oronade for the sinus congestion, and she is to also use stool softeners and laxatives on a daily basis, but in small amounts. And you're like, well, why is he telling her that? Well, what did he say up here? She was addicted, or she's abusing the laxative. So he's saying, okay, lady, if you are having this this constipation situation, okay, still take them, but just take them in small amounts. So you're like, well, why does he saying that? What can a laxative do to you? Well, if you don't know, you Google it. If you are taking these laxatives and these stool softeners, it's causing you to deplete your body of the necessary nutrients and could cause you to be dehydrated. So that's why he's telling her, hey, you can take them, but take them in small quantities. Okay, let's see what the next thing is. So let me just tell you, part of these records are typed. Part of these records are handwritten. These records are from 1986. Because of HIPAA, we unfortunately cannot get our hands on records from 2016. And again, our goal here is for you to learn the process. So they have a post-hospital instruction sheet here, which was very popular in 1986. But what they're saying here, principal diagnoses, condition established after study to be chiefly responsible for the admission. So the doctor wrote this in, and then this is what the coder coded in ICD-9. Keep in mind, we're not coding ICD-9, we're coding ICD-10. So as the coder, one of the things that you have to do is ensure that you follow the guidelines. So when you look at the guidelines, the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital, it's really the dehydration. Yes, they had gastroenteritis, but let's think about this for a minute. What was the visit focused on? Go back to your discharge summary. She was admitted and given IV fluids for the last 2 days. Why was she given IV fluids? Because she was dehydrated. The other thing you probably are thinking, your wheels are probably spinning, am I going to assign the PCS code for the IV fluids? And the answer is no, because it's captured by the hospital charge master. Okay, so let's continue. We got this post-hospital instruction sheet. We have this admitting record, and you see, even though these records are old, we still had to comply with HIPAA, so you notice that these records have been de-identified. And because of the security breaches, etc., lots of organizations are not willing to give us medical records for teaching purposes. This hospital in New York, they gave them to us, and of course we had to de-identify all these particular areas. So here, this next document, which is page 4, is the history and physical exam. So I'm going to give you a few seconds to read this note. And let me see if Donna's still here with me. Oh, now I see Susan is here. So for those of you who are just joining, because of the Mother's Day holiday, I came in at 2 o'clock to record the lecture, so you'll want to make sure that you start from the beginning. And what I'm doing right now is going over the inpatient case number 11. I will give you some tips at the end, and then the session will be ending very shortly. So back to the history and physical exam. One of the things I'll recommend that you do is print out these records, because you really want to be able to read them, do your research, make notes on them, etc. So let's continue reading. Okay, so now that I've finished reading the history and physical exam, I want to pull my worksheet back up and see if there's anything else I need to add. Well, they talked about, I see something related to the flu. And so I might say, okay, I didn't see that in a discharge summary. I need to see if they actually treated that. The other thing that you notice is that the patient is allergic to penicillin. So that's something else I'm going to add to my worksheet. Again, you see, I haven't coded anything yet. I'm just making my list of things that I think I want to code. And of course, oh, I forgot to highlight my POA here. And this flu, I'm not too sure about. That might be one of those things that I say I need to query about. Okay. If I feel this significant, patients come into the hospital all the time with a bunch of conditions that, if they're stable, they have no bearing on a hospital stay. The doctor doesn't even treat them. Okay. So they mentioned the spleen again. She had a splenectomy. They also mentioned that she had a herniectomy, herniorrhaphy. They also mentioned that she had meningitis in 1982. So again, am I adding these to my worksheet? Well, what does my guidelines say? Other diagnoses are all conditions that coexist at the time of admission that develop subsequently or affect the treatment received and or the length of stay. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. Okay, so I will tell you the answer key that you will see come Thursday. We didn't code the splenectomy. We didn't code the flu. You know, we might potentially query for the flu, but really they didn't talk about it a lot in the medical record. Okay, so that's the H&P. Here's where it's going to get fun. Now, I mentioned printing out the record. If you don't have a lot of paper, you know, what you can do is just read it from the screen and take notes. Some of this you may have to blow up real big. Handwriting is so difficult to decipher when you're not used to the doctor's documentation. So I can tell you that for the most part, I can read this information, but not all of it. So let's see. 12886. No BM. No bowel movement. ABD. Abdominal cramps. Oh, negative for abdominal cramps. Negative, no nausea. Abdomen looks like it's distended. They say increase in something that's itis. And then after that, they talk about SS, a stool softener. So again, you're probably like, well, she can't read these words. How can we read these words? It takes time. You can blow it up and try to read every other word to get the gist of what's going on. So 129, he says, feels less distended, no good BM, bowel movement, better hydrated, taking clear and soft, so she's probably on clear and soft liquids, does okay. Increase something, DC, the IV. Then 12986, there's a note, says patient followed by NPHCS prior to admission for homemaker service to follow. So nothing really there that you needed to for coding purposes anyway. Okay, so the next sheet is an admission process note. They say chief complaint, nausea and vomiting, diagnoses, flu, gastroenteritis, dehydration. And here they say provisional because when the patient is admitted, they're just trying to work them up and figure out what's going on. Okay. After that, the doctor's orders. So, Dr. Whoever, name is blacked out, ordered a CBC, UA, chest x-ray, SCC2, electrolytes, looks like an enema, 1,000 cc's normal saline, follow IV with something, and it says RIV, and H&P done. Then they talk about medications. They say Phenergan. So again, remember I said first, read through the record, define everything that you need to define. So what's Phenergan given for? Phenergan has a couple of reasons why it can be utilized, but one of them happens to be nausea and vomiting. It makes sense on admission that they would give her Phenergan for the nausea and vomiting. And actually, the doctor is really smart. He actually says it right here. I know you're like, oh, I can't see that, but N/V is for nausea and vomiting. Okay. Then they mentioned the Symmetril again, which we talked about on the discharge summary. That's the condition for Parkinson's. SSE, stool softener enema, this PM. Gave her another medication, gave her some Demerol, Phenergan. So medicine for pain, medicine for the nausea and vomiting. Okay, so again, the notes just continue. So what you do with your worksheet is you're just going through the record to see if there's anything else that you need to pick up. Now, as you guys can see, I'm going to close out of this note. As you guys can see, this is not a start this on Wednesday night type of deal. So a couple of things I've given you for week 2. Number 1, I've given you a template to follow for your posting, because your post has to consist of the responses for the two cases by Wednesday. So the file that's listed in here, let's see, what's it called? Oh, the little box is so small. Let me go to my box. It is called Roundtable Student Template. You'll notice that I actually have in fact given you the answers for case number 11. So what you'll want to do is just go through that and make sure that you can locate all the diagnoses. We actually just went through that. And then your second case is where you're going to be out there on your own. And I will tell you, I'm not going to give you the answers each and every week. What we're going to talk about is the process. Okay. Again, in the round table, the goal is for you not to get 100, because you're going to get 100 if you participate and if you follow the rules. So rule number 1, first post by Wednesday. First post must include your answers to both cases. And let me just pull this up, because I think it's important for you to see the format so that there is no confusion. So basically what you're going to do is read through case number 11, confirm these codes. We actually just talked about them. And then you got to do case number 39, but you're basically going to do your work on this template, copy this box here, go to your round table, and you're basically you're basically going to hit that respond button at the top, post in your answers, and then you're going to just say something like initial post, and then your initial post will be there. You see how nice and clean that is. People can understand what it is you are typing. Okay, I'm going to delete that. But that's basically what you're doing. So let me pull the slides back up again. So case number 11 there, I'm just giving you a few tips. I actually even gave you all the answers for case number 11. So let's look at case 39. You'll notice this week, no PCS codes. Why? Any type of procedures that you see listed in these two records, IVs, chest x-rays, those are captured by the hospital charge master. We're not picking them up. The hospital doesn't pay a coder $25, $30, $40 an hour to code chest x-rays. Chest x-rays are picked up by the charge master. They don't make us a lot of money. But procedures such as coronary artery bypass graft and your surgical procedures, that's what makes us the money, and that's what your inpatient coder is going to pick up. So for case 39, you got your principal diagnoses, your 6 secondary diagnoses, no procedures at all. Okay, so there are lots of files for you to upload or download to the from the files area. I highly recommend that you download those. Also in the chat box, I have provided a link to a recording for you to use to determine the MSDRG. And let me just show you why you need that. Let me go back to the class. Questions number 7 and 8 ask you, what is the DRG? What is the relative weight? So if you follow the instructions that I've listed in this tutorial here, after you go through the record and you do your coding, this tutorial that I've recorded for you will help you get your MSDRG for your second case. But this recording that you'll see here is what I used to show you how to do the first case. All right, so I know that you ladies were not here at the very beginning, but at this point, do you have any questions for me, keeping in mind that you're going to need to go back to an hour and a half ago where this party started? Okay, well, seeing that there are no questions for today, I wish you good luck with your roundtable cases this week. If you have the time, I definitely would re-listen to this today, if not tomorrow. The good thing about these sessions is that they're recorded and they're available 24/7 as long as there is no system issues. So again, as I stated at the very beginning, the reason that I had to move this up is because my family is taking me out for Mother's Day, and wanted to wish all the moms a happy Mother's Day. And I'll see you next week.